Assalamu alaikum. I'd like to thank the organizing committee really for this session. Okay, since I think it's a very common injury, and I hope that most of you can get some information about it, okay, to deal with similar cases. So what we will talk about is the reconstruction of this ligament. I think we are in succession. The first we will talk about the pathology, and the second we have talking about the algorithm, and then the capsulodesis, and here I will talk about the reconstruction. But as you see, the title is Scapholunate complex reconstruction. It is not a ligament, and this is what we will pass with in the first. So previously, in the old times, we thought that scapholunate dissociation is just the injury of the ligament, okay? But depending on this, the classification of Gisler has been stated, which we used it a long time ago, which were the four stages. But recently, with new investigations, you can see this is an MRI, 3 Tesla, for a patient with an acute injury. What can you see in this MRI? What we can see is, this is from the radiology journal from USA 2022. You can see quite well that the injury is not only limited to the scapholunate ligament. It's complete avulsion of the whole attachment to the scaphoid. So it's whole radiocarpal ligament injury, and even the DIC ligament injury. And it's just sparing the STT ligament. Another imaging for another patient. You can see this is an arthrogram for the normal scapholunate complex and a diseased one. You can see the difference here. In this one, which is on the left, you can see the septum. And on the right one, you can see that the contrast has filling the space. This means that the septum has been injured, which we will talk about in a few minutes. So, first of all, what is scapholunate complex? So it is a complex, it's not a ligament, and all depends on each other, and we will see the difference in the history passing through this complex. First, it is a scapholunate ligament. Second, it is a dorsal intercarpal ligament, okay? And the third is the septum that is between the scapholunate ligament and linking into the dorsal capsule, which has been described by Christophe Matholin in its repair. Depending on this, if you looked more precisely in the EWAS classification and the recommendation, you will find that in this last column that what they state in, for example, stage 3C, that we have a DIC lesion or radioscaphocapitate and long radiolunate, and then it continues. So they added the complex injury. And they stated since the EWAS classification has been presented. And what about the treatment that have been suggested for the scapholunate, if we go through the history of it? First of all, they thought that it is a problem with the scapholunate ligament alone. And so this is why it started by Pronelli and Pronelli in 1995 by using a slip of the FCR to reconstruct both, or to limit the scaphoid flexion. So he passed, as you can see with the tendon, slip of the FCR and fixed it to the radius. Its complication is that we have a limitation of flexion. Modification occur that to fix it in the leonate, to anchor it to the leonate, so this increases the flexion range of motion in the patients. Afterwards, coming Professor Garcia Elias in 2006 with a 3 ligament tenodesis, where he tried to reconstruct, I think, the 3 of them, the STT, the scapholunate ligament, and the dorsal part of the leonotriquetral ligament. So you started to repair the 3 of them, which is trying to compress the proximal row, okay, and limit the flexion. Afterwards, coming Luchetti and Atsai, and they tried, this is from the book, the chapter book, then comes Greg Payne, and he modified it to the quadruple ligament reconstruction. So he returned it back to fix it to the scaphoid in a way to reconstruct the dorsal intercarpal ligament. So he thought about the scapholunate complex. Other measures, as you can see, and we have passed by this, bicorella and the antipronation spiral tenodesis and others. But when we look at the literature, I know Luc de Smet, he is from Belgium, and I have been there for a long time. And he did his study, and I remember 2013, and he tried to see the results of the ligament tenodesis effect. And he found that the patients are satisfied, but still there is a problem. It is not the ideal thing, okay? Since he found that the gap decreased from 4.25 up till 3.29, and even the flexion angle from 77 to 65. So he stated the patients are satisfied, but they are not the ideal thing. Which in turn, coming Greg Payne 2 years ago with his publication, which is, as Dr. Abdelaziz stated, why are the surgical outcomes of the scapholunate instability still so far from the ideal? Why? Why? Because we only repair or reconstruct the ligament and not the complex. Secondly, coming Elizabeth Haggard and stated the importance of the proprioception for the wrist and the importance to preserve the nerves. As Professor Garcia Elias stated, he tried to preserve the nerves as much as he can because this helps to maintain the proprioception. So, so this protects the wrist further. And so, how to reconstruct a scapholunate complex? To do it open or to do it arthroscopic? I think in order not to be invasive and to save as much as the nerve supply of the joint, it's better to go arthroscopic, okay? For us, or for me, I thought that the best technique for me, at least, in this stages, which is stage where it is unrepairable, reducible scaphoid flexion, and the lunate is not translated, is to use the technique presented by P.C. Ho. I know him by myself, which he presented the box technique arthroscopically. The idea, as you can see in the photo underneath, that he tried to do both, to reconstruct the scapholunate and to link the scapholunate to both capsules, to the volar and dorsal capsule. And he tried to reconstruct both, the volar and dorsal part. I thought that it will be a good technique and it's done arthroscopically, but I will show you my results. So the idea is that he make a loop or a box technique that's surrounding the scaphoid and lunate, and then with tightening it, the space compresses. And he did this outside the capsule. So he maintained the link of the scapholunate to the capsule. He do a capsulodesis also, which gives further stability. So this is one of the cases. It's by one of my colleagues, really, Dr. Muhammad Hassan from Alexandria. So we first depride the space, and you can see how wide it is. The first important of all, if the scaphoid is flexed, we have to remove the fibrosis between the scaphoid and lunate, and even the contraction at the STT space. So we go with a shaver and with a hook and try to correct the scaphoid. And if it doesn't correct, the procedure is abandoned. Oh. Okay. Voila. Again. Okay. And so, after this, we try to reconstruct by doing 2 tunnels in the scaphoid and lunate, where we try to elongate transversally the dorsal portal okay, with a 3-4 portal by 2 centimeters transversally, and also volarly between the palmaris and the FCR. And in this incision, we can take the palmaris, as you can see here, tendon. Afterwards, we try, you have two ways, either to correct the alignment of both by key wires, or either to do the tunnels that can correct the malalignment of the scaphoid and lunate. Afterwards, okay. Then, after correction, we try to do our tunnels to increase it by 2.5 millimeters and then to pass our graft. So with a grasper, you can go through the tunnels and obtain the graft from dorsal to volar, so you can tighten it at the back. And you can see here, when we tighten, what happens? You can see, when we tighten it, the space closes and the proximal row is tightened. And then we make our knot, suture both ends together, and we tighten it with a PDS suture. And this is the end with a very nice scar. It's minimally invasive with a good results, as you can see here. A little bit limitation of the dorsiflexion, but I think it's accepted. It's about 80 degrees. The results of Piseho himself, he did it for about 17 cases. And as you can see, he had the average scapholunate space was about 2.9 millimeter, and he had a recurrence of the DZ in about 4 patients. And also he had ischemic manifestation in the proximal pool in 1 case. For us, we did about 7 cases. We had, of the 7, 2 of them having a flexed scaphoid, but which was reducible. After doing it, our outcome was quite well. 6 of the patients returned back to their normal activity, and they were about 90% of the contralateral wrist range of motion and grip strength. And the scapholunate distance was about 2.5 millimeter. But we have some complications, which I think we have to stop at this complication and think. The first of all, the scaphoid that we have corrected it, which was flexed, it returned back to flexion. And I don't know why. And this is one of the questions. Second, we had a case of avascular necrosis of the lunate, which I think is related to the blood supply of the lunate. You know, this is one of the, this picture I have taken from the book of Kimbuk. And as you can see, the blood supply is coming to the lunate a little bit ulnar, directed to the triquetrium. And so and a little bit proximal. So I think if we go a little bit radial, we may save the blood supply of the lunate. The second is the flexed scaphoid. Why it has returned back to flexion? I think because the secondary stabilizer have been affected, which is the STT ligament. And I think only reconstructing the scapholunate is not enough in such cases. And I think even I talked with Piseho, he had some cases that the scaphoid has flexed once more again. And I think we have to think about that, because this causes malalignment, which in turn, on long term, can cause osteoarthritis. So, still also, we have to have a long-term follow-up of this ligament reconstruction. Does the ligament revascularize? Does it re-innervate? Does it, like the ACL ligament, it became ligamentization of the tendon or not? We don't have really a long follow-up. So, as a conclusion, it's a 360 degrees reconstruction for the volar and dorsal in link with the posterior and anterior capsule. And really, it is minimally invasive with good vascularity and increased healing and minimizing complications, with an easy rehabilitation and faster recovery. But still, we have a problem that the long-term follow-up, we don't have it much, and with a very minimal complications. Thank you.
Thank you, Dr. Amr, for a very nice presentation. Now we conclude the session and we have a coffee break.